Welcome into Healthline 3. I'm Courtney Butts, and Healthline 3 is where we like to focus on ways to live a happier, healthier, and pain-free life. Today, I'm joined by Dr. James Barnes with the Highland Clinic. Thanks for joining us.
Thank you.
Absolutely. So you're a bariatric surgeon local to this area, and tell me a little bit about what you do as far as weight loss, because that's our topic today. We're talking all about weight loss, and people love to talk about this, so tell us what you do in that realm.
Right, and we kind of do everything in that realm, honestly. I mean, we have kind of a unique practice where we can offer really all the treatment modalities for obesity. And so we kind of focus on two big broad areas. One is the bariatric surgery, the gastric bypass and the sleeve gastrectomy. And then the other big part of our practice is the GLP-1 injections, the weekly injections that everybody's heard so much about recently. And we see really good results with those. And so we kind of focus on those two areas, but we also, of course, get into diet and exercise and nutrition and all these things that are all part of losing weight and getting healthier. And then, what we've learned is it's not an either or with any of those things. For successful weight loss, especially people that start getting into that morbid obesity range, you kind of have to combine it all a lot of times. And so we do that a lot, where it's sometimes surgery, medications, diet, the whole package deal.
Absolutely. Yeah. And so you're a bariatric surgeon, so that's like your specialty, but you also have performed other surgeries as well. So what got you excited or into surgery in the first place?
Yeah, so I'm a general surgeon, and I still do a lot of general surgery, and gallbladders and hernias and anti-reflux surgery and things like that. So that's also still a good part of my practice as well. And that's how I started out, was general surgery. And then when I first got into practice, which was, almost 30 years ago now, I started getting into bariatric surgery and just really enjoyed that. And that's become the biggest part of my practice. And it's just, I just love all aspects of it, because it's the surgery is technically challenging, and I enjoy doing the actual operations. But then a big part of it too is just developing relationship with patients and seeing them go through this dramatic life change where they lose this weight and they get healthier, and sort of walking them through that and seeing the improvements in their life. And that's just, I never get tired of seeing people go through that. That's just always a lot of fun.
I love that. Yeah, you kind of walk through a really life-changing event in their life, and you get to walk through that with them. So that's awesome.
Yeah,
I love that.
because we spend time with them before preparing for the surgery, and then we have a very comprehensive, extensive aftercare program where we meet them on a regular basis and just kind of again walk them through step at a time as they go through this journey.
Right. Okay. And so we mentioned this in our midday newscast. I think that this is relevant to everyone. We're going into the holiday season. Halloween is like 6 days away. Then Thanksgiving and Christmas, New Year's, and then we still have Mardi Gras on the way. So the holiday season can be a little nerve-wracking for some people, or maybe you just totally neglect your health a lot of times during this season. So what is something that you would challenge maybe someone in our audience to do to focus on their health?
Yeah, so, and honestly, I think living in Louisiana, there's challenges year round. I don't think it's just limited to the holidays, but that's, I think, when people kind of, it can be more challenging. And I think it's a lot of factors. First of all, we all get so busy during this, this upcoming time of year. There's all the holidays and family gatherings, and there's just a lot of stuff going on. And with all these family gatherings is always lots of food, and so there are more challenges there. And so part of and we just did a support group last night where I talked about a lot of different ways to sort of work on those sweet cravings, the sugar cravings, which are so prevalent. And we talked on the newscast a little bit about portion control, which is a big thing that I emphasize. If we're not saying you can't ever eat this or that, but you just try to eat less of it, and then you can still get the satisfaction from eating something. But if you eat a half a portion, you've cut the calories in half. And so that really does make a huge difference. So that's one good trick. I mean, there's a lot of stuff we can talk about. Eating a little something healthier before you go to a gathering where you're not going to be as hungry when you get there. And then, of course, a lot of the stuff that we offer with the medications and the surgery is going to make it where you're not as hungry as you were. You're not able to eat as much, and so you kind of already have the tools necessary going into the holiday season from the stuff that we've prepared ahead of time.
Exactly. It's like cutting out that food noise when you take those
Yeah,
injections.
that's a great way, and I hear that a lot. People on the injections really, when they start them, because it's such a sudden change, all of a sudden they're on them, and that's how they describe it a lot. That food noise just kind of goes away, and it's not the driving force all day long that they're thinking about. It's just, oh, it's 12 o'clock, I guess I should eat some lunch, but it's not like wake up at 6 o'clock thinking, what am I going to have for lunch today?
Yeah, and I think a lot of times food can be a form maybe of a coping mechanism during stress, and so it helps, I would think, help individuals find a way to cope with stress in a different way.
Yeah, and obesity is a really complex disease. It really is, and a lot of the root of it is, for most people, especially those that are in the morbid obese category, it's a real food addiction. And so it's that's a lot of the sort of the counseling side of this that we talk with all our patients about a lot is battling with that, and we eat because we're hungry, but a lot of times that's not the main reason we eat, and a lot of times we call it emotional eating, and it can be any emotion under the sun. I eat because I'm happy, because I'm sad, because I'm depressed, because I'm angry, you name it, and that will trigger certain people to look towards food as sort of a coping mechanism. And so we try to help them understand that, and sometimes just understanding that is a lot of the battle. Realizing, okay, I'm really not hungry. Why am I up here, rummaging through the pantry trying to find something to eat? Right.
So you mentioned support groups earlier. Is this something that Highland Clinic offers for your patients?
It is, yeah. And so we do a monthly support group that I'm at most of those myself, running those, and we just had one last night, I think I mentioned, and it's just a great opportunity to, because the patients can hear me talk all day long, but sometimes it's nice to hear from other patients and what their experiences have been, and patients come up with stuff all the time that I didn't think about, or and so and that's where they're always great. We have a lot of great interaction, and I think that's really helpful for a lot of people.
I love that, and it's for someone who's had the surgery or is on the injections. It's for really anybody?
Yeah, either one. It tends to be more my surgical patients, but we certainly welcome anybody. And even if I didn't do your surgery, we have some people. Had a lady drop in last night that had surgery, out of state, but wanted to come.
Very cool. Yeah, I love that. And knowing that, bariatric surgery, we can kind of talk a little bit about that. Like you mentioned the sleeve gastrectomy, right? And the bypass are ones that you specialize in.
And so when we talk, and I'm going to take it a step back, kind of the initial fork in the road for a lot of people is, do I want to look at surgical options or do I want to look at medical options? And that's part of, again, we offer both. And so if you go to somebody that offers one, that's where you're going to go. If they offer the surgery, you're going to probably have surgery. If they offer the injections, you're probably going to have the injections. Well, we offer both. And so we can really help tailor a program to each individual patient, and figure out what's going to be the best fit for them to get them the best results. Part of it's talking to the patients too. Not everybody has the same goals with weight loss. Some people, not everybody wants to be a size 4 and get ready for bikini season next year. Sometimes it's about getting healthier. Sometimes they want to lose some weight, but not. There's a lot of everybody kind of has different goals, and so that's part of what I try to do is not just use the same formula for every patient. What are you trying to get out of this, and then I can help tailor the program to fit. And so sometimes that's surgery, and we tend to do the surgery for the we base a lot of this on the BMI or the body mass index, and so I tend to favor the surgery for the folks that are a little heavier. Sometimes we'll try the injections for the folks that aren't as heavy, and we're actually allowed to go a little lower on the to qualify for the injections, you have a BMI of 27 or greater. For the surgery, it has to be 35 or greater. So that 27 to 35 range on the BMI, where people aren't quite heavy enough to qualify for surgery, those are usually great candidates to look at the injections too.
Okay. Well, if you're just joining us and you have a question for Dr. Barnes, we're talking about weight loss. You can give us a call at 318-219-4569, and we'd love to hear from you and answer your questions. He's a bariatric surgeon, so we are talking about weight loss surgery and weight loss injections and of that nature. So yeah, so we were just talking about, I'm just blinking.
I kind of took your question another direction, but you were asking about the surgery and what we do there. And so we offer 2 operations for weight loss. And weight loss surgery or bariatric surgery has evolved over the years. There's been multiple operations that got real popular for a while, and then they kind of faded away. And there was an old stomach stapling that was done for a long time, lap bands that were done for a long time, the gastric balloons, there, just a lot of stuff that kind of came and went. There's been one operation that's been pretty consistent for the last 60 or 70 years, and that's the gastric bypass, which is still the most common operation that I do for weight loss, and I think overall probably has the best results. And then the sleeve gastrectomy is the other operation that we do quite a bit of as well. And so they're both very effective for weight loss. The nice thing about the surgery side is that for most people it's going to be a long-term weight loss. With the injections, first of all, you don't see the amount of weight loss with the injections that you do see with surgery. But the long-term game is also what still has to be kind of sorted out with the injections, because we know when people stop them, most people are going to start gaining their weight back. And so I think that's where surgery offers a big advantage, because for most people it's going to be a permanent weight loss. Once you lose that weight, you're going to lose it. Now you can gain it back, but most don't. And so the bypass and the sleeve, we tend to see a little better weight loss with the gastric bypass. But it's also a little bit bigger operation than the sleeve, and so that's kind of the trade-off. And there's other pros and cons, and again, that's something we go over in detail. We do a free seminar every Tuesday morning for people that are interested in surgery. Nice. And we spend some time just kind of in a very small group talking about a lot of that, kind of pros and cons of the different surgical options. And then I meet with the patients individually afterwards, and we try to again, find out what's going to be the best fit for them.
Yeah. Do you have to register for that?
You do. Yeah. You just have to call and make it more. And then the other thing we'll do when patients call, we verify their insurance to make sure they're going to have coverage for weight loss surgery. And fortunately, most insurances do cover weight loss surgery. A lot of people think it's a cash pay thing, but most of the time surgery is covered by insurance. I would say 95% of the operations that I do are covered by insurance. And so most of the commercial insurance carriers will cover it. We take Medicare as well. We don't take Medicaid as a primary, only as a secondary, but all the others, most of them will cover. But we check and verify that when patients call if they're interested.
All right. Okay. And so the difference between the 2 surgeries, remind me, one's the small banana and one's the large egg. Which one
exactly. is Exactly. That's a good analogy. So the gastric bypass, we staple off a small stomach pouch about the size of a large egg, and then we bypass the rest of the stomach, and then we hook up the intestine to that small stomach. And so they fill up faster because their stomach is much smaller, and then they don't absorb the food quite as well from the bypass part, so they don't get as many calories out of a given amount of food. With the sleeve, we staple off the lateral part of the stomach, so we just leave kind of a narrow tube of stomach. We remove the outer part, and so it's about the size and shape of a small banana, like you said. So you downsize the stomach, people fill up faster. And then the other thing that both these operations do for most people is they decrease your appetite. Your hunger level usually goes down pretty significantly. There's a hormone that you can measure in the blood that stimulates hunger called ghrelin, and that hormone level drops dramatically after surgery with either operation. And so Again, like we talked about the food noise earlier, and that's kind of what this does as well. It just lowers people's appetite, so they're just not thinking about food as much.
Right. Okay. And so, let's say somebody is interested in the surgery and they meet the qualifications, they've got the insurance, they've got the BMI. When, let's say realistically, I'm the patient coming to you and having this consultation, when could I expect to have that surgery from the consultation? When do you think that usually happens?
So it varies a little bit. There are some steps that we have to go through, and sometimes that's determined by the insurance company, and unfortunately some of the insurance companies require a series of monthly visits before they will authorize the surgery. Honestly, most of the time they do that to sort of block access to bariatric surgery. They're trying to just put up some roadblocks. I wish that wasn't the case, but it really is. So sometimes we have to see people, and it's usually between 3 to 6 months, where we have to see monthly for a little while. Now, they don't all have that requirement. A lot of them don't. So some of them, a month, 6 weeks, something like that, and we'll have them ready to go. We usually ask them to lose a little bit of weight before surgery. We have to do a couple little tests on them before surgery. So there's a few steps. If there's not a lot of insurance requirements, frequently 4 to 6 weeks, we can get the surgery scheduled. Sometimes it's a little bit longer if we have to satisfy those requirements.
Okay, and can someone do medical weight loss, like the injections, to help lose weight before the surgery?
They can, and we do that a lot too. We actually, before surgery, sometimes we use the injections. A lot of times we use Adipex too, which is a weight loss pill that a lot of people are probably familiar with. It's also called phentermine. It's a pill you take once a day, and it does decrease your appetite as well. And so that's a really good tool that we use a lot also, and we use that a lot before surgery to help people lose a little bit of weight going in. Because when they lose that weight before surgery, it shrinks down their liver, so it's out of the way. It shrinks down their abdominal fat a little bit, so it makes the surgery a little bit safer too.
Okay, gotcha. Okay, so we were talking off air earlier about like revisional surgeries or conversion. You probably can obviously speak to that a little bit better than I can, but tell me a little bit about that.
Yeah, and so that's a big part of what we do too is, and I mentioned earlier, there's a number of older operations that aren't done as much, and so sometimes people will come in that have the old stomach stapling or have a lap band in, and operations that we know long term don't really work very well for most people, plus there's complications with those. So we will frequently do operations to most commonly convert those over to a gastric bypass is usually the route we go with that. We also see patients with one of the complications that can occur with a sleeve is that about 10% of people have reflux problems with the sleeve, and we see that sometimes. And so sometimes that can be managed with medications, but sometimes the medicines just don't really help a lot. The Prilosec and Prevacid and Protonix and those types of things. And sometimes people still have really bad reflux even taking the medications. And so that's another group of patients that we can look at doing revisional surgery and convert that sleeve over to a gastric bypass, and that usually knocks out 100% of the reflux, and then they usually get a little added weight loss with that as well.
Okay, yeah, because you're going from the small banana to a large egg,
Correct.
So it's a little bit smaller.
Yeah, a little smaller.
There.
You get also the malabsorption because of the bypass part of the operation, and so we do see a little more weight loss when we do that as well.
Okay.
And by doing these robotically, it makes these revisions even a little easier to do, a little safer to do. We haven't talked about the robotic surgery in a little while, but that's how we do all these operations now. Usually 5 or 6 little incisions across the belly, and then we go in robotically. So what that means, instead of me standing at the table working through those little incisions, we have the robot at the table, and the instruments are attached to the robotic arms. And then I'm over on the other side of the room sitting at a console, and then using hand and foot controls, I'm controlling the robotic arms that are moving the instruments inside the patient.
Wow.
It's a really cool, crazy technology. But because of that, we can the dexterity inside is so much better. I can do things differently,
more precise,
more
maybe.
precise. And then after, so it allows us to do stuff that we couldn't do before. And then also on the patient side, patients have less pain afterwards. We've cut the hospital stay in half by doing it robotically. The recovery's quicker, the complication rate is lower. So we see some really nice advantages to doing all these robotically now.
That's awesome. Well,
Yeah.
cool. Well, Joe, thanks for joining us. And what is your question for Dr. Barnes?
I was wanting to know if maybe they had a age limit on this surgery.
Yes and no. My standard answer to that is our age range is from 18 to 70. Now, it's not like 100% cut and dry, but as we get older, the risk of surgery go up. And part of my job in all this is weighing the risk of the surgery versus the benefits of the surgery. And as we get older, the risk of the surgery to go up a little bit, and so we have to keep that in mind. And so it depends on why we're talking about doing it, what are the medical issues there. We have done older than 70, and 75 is probably about the upper limit that we would get to, unless somebody's having a real severe complication or something. But somewhere in that 70 to early 70s range is about the upper limit that we would offer surgery for.
Okay, well, thank you, sir.
You're welcome. Thanks for your call.
Yeah, thanks, Joe, for joining us. And if you had a question for Dr. Barnes, give us a call at the number you see on your screen, 318-219-4569. And I'll continue asking my questions. So we talked about surgery, and a lot of times, I'm sure a lot of the prep that you're doing with your patients is talking about after surgery. The recovery period. Can't really tolerate some foods probably as what you could before. So take me through that process.
Yeah, so the aftercare is a huge part of this, and a part of being successful with this. If you just do the surgery and then send people on their way, a lot of people are just not going to do very well. And so the aftercare, we really stress that. It's a big part of what we do. And there's a lot of aspects to it. Part of it is the diet that you mentioned, and we start with just a gradual progression of adding foods back to your diet. We do clear liquids for 2 weeks, then we do full liquids, which is the cream soups, mashed potatoes, pudding, yogurt, that kind of stuff, for another 4 weeks. So they're on liquids for 6 weeks. Now, they're not very hungry. I know that sounds like a long time to go on liquids, but you don't really have much appetite after surgery. And then we start soft, solid food back. And so, so part of it is the diet progression. Part of it is if there is a problem that comes up, we want to catch it early. And so, that helps with that. If people are starting to get off track with their weight loss a little bit, if they should have lost 15 pounds since their last visit and they only lost 8 or 10, then we can look at, okay, well, what's going on? There's probably a few too many calories coming in somewhere. Let's look at what you're eating, what you're drinking, and, again, kind of nipping that stuff in the bud before things get away. And so that's a lot of it. We draw blood work periodically to check vitamin levels and make sure, that those are where they should be. So just, people just do better. Part of it also, I think, is the mentality of just knowing that you're going to come in periodically. I think, we all do better when people are watching us a little bit. And it adds some accountability to it, keeps people focused on it a little better. And I think when people come in regularly, they just tend to do better.
Yeah, okay. And you mentioned vitamin levels. Do you have like a supplement regimen that you put your patients on? Yeah,
we do, and it's pretty simple, really. You do have to take a multivitamin with iron daily forever and ever after bariatric surgery. And so you can do that in different ways. We have the first 3 months, I don't like patients to do a vitamin pill because they're kind of big and we don't want that getting stuck. So either a chewable or a capsule that dissolves after you swallow it, or a vitamin patch. That's what a lot of our patients wear, is just a skin patch you wear and you change it once a day.
Okay.
So we sell all those out of the office just to make it easy for people to get right away. So you have to take a multivitamin every day. And then with the gastric bypass, you don't absorb vitamin B12 very well. And so we have to supplement that with a monthly injection of B12, which patients just do at home. It's just a little tiny needle, like an allergy shot or an insulin shot.
And you also have that.
They get from the pharmacy because it's a prescription thing.
Oh, gotcha. Yeah.
But we just write it. They fill it, do it at home once a month, and so you take a multivitamin. You do if you've had a bypass, it's a B12 shot once a month in addition to that. And as long as you're doing that, we see very few malnutrition problems, things like that. People usually do very well, but we do keep an eye on those levels just to make sure. And then if we get labs back and showing that something's deficient, then my nurse will call the patient, and usually it means they've kind of gotten away from taking their multivitamin a little bit. Encourage them to get back on that.
Okay. Good advice there. And so what about exercise after surgery? When do you typically suggest waiting to resume that?
Yeah, and there's really not much of a limit. We don't put any activity restrictions on people after surgery by doing these robotically. You can kind of go back to stuff whenever you feel like you're ready. Obviously people aren't going to be running marathons the first 2 weeks, but we encourage walking immediately. We get people up the day of surgery up walking, and so the more you're up moving around, the better. And then just gradually, as you start to kind of get over the surgery over those first few weeks, encourage you to get more active, do more stuff. Some people really get join the gym, start working out. We see a lot of that, and I encourage people to do that. We know that exercise, it's not a big part of weight loss, and so you don't have to exercise to lose weight, and that's a misconception that a lot of people have. Exercise is great for you in a lot of different ways. It's good for your heart and your lungs and your muscles and your bones, and so I encourage people to do it, but it's honestly not a big weight loss tool. Most of weight loss comes from restricting calories in your diet, which is what the surgery helps to do, or the injections as well. But the exercise is not a big part of the actual weight loss, though.
Right. Okay. So switching gears to the injections, we have a couple minutes left. 27 BMI is what is recommended. Now, is that something that is regulated by insurance companies, or is that just across the board?
Yeah, it's all medications come out with guidelines that you have to follow, and so with the weight loss injections, they're not approved by the FDA for under a BMI of 27. You do not have to be diabetic. That's one. Now Ozempic, you do have to be diabetic to do Ozempic, but Wegovy, which is the same thing as Ozempic, it's just branded under a different name, but its indication is for weight loss, and so you don't have to be diabetic to do the injections. And so, BMI of 27 or greater, you're going to be a candidate for that. And the program we offer, we use the compounded or generic version of the medications, because the problem with the brand name meds is that a lot of times, more often than not, insurance does not cover them, and they are crazy expensive if you're paying cash for the brand name. Now, the compounded version are still expensive. It's still pricey, but it's about a third of what you would pay if you're buying the brand name ones. And so that's the program we do, and then we don't have to worry about insurance. We don't have any availability issues. We can get access to those. We see the patients monthly at first for a while, and then we send the prescription to the pharmacy in Austin, Texas, where we get all this, where this is all compounded, and then they direct mail it to the patient's house, and then the patients just do it themselves at home once a week.
All right, yeah, and so with the injections, they're cheaper because you're compounding them, but I'm sure it depends on where you're starting, the milligrams or the dosage or whatever. Will that change the price as well if you go up?
And there's different people do this different ways, and we're actually kind of looking at possibly making some changes right now, but the way we do it right now, we have a set price regardless of your dose.
Okay.
And so the price, and a lot of people will sort of taper. There's pros and cons to that. Some people will start at a lower price, but then as the dose goes up, because there's 5 different dose increases when you start these, and so some places, as the dose goes up, the price goes up, and I didn't do that at first because I didn't want price to be a determining factor in whether or not you go up to the appropriate dose.
Right. And
so we kind of set the same price. But the advantage of starting lower is you can kind of try it out at a lower dose, lower price, and see how that's going to
There we
work for
go.
you. So there's kind of pros and cons to both. We're still sort of, we're contemplating sort of changing that around a little bit. But as of right now, we have a set price regardless of your dose.
Okay, cool. Well, where can people find you if they are interested in scheduling
Yes.
surgery or injections?
Absolutely. So I'm at the Highland Clinic on Burt Coons. It's adjacent to Christus Highland Hospital. If anybody wants more information, they can call the office. It's 318-798-4433. We have a Facebook page. It's just under my name, James Barnes, MD. There's a website for the Highland Clinic, just highlandclinic.com, and you can go into providers and find me over there too. So lots of different ways that you can track us down.
All right, thanks Dr. Barnes for joining us. It was great, very informative, and we'll see you back here next month for another Healthline. And if you missed this, it's at ktbs.com/podcast. Have a wonderful Friday and weekend.